Great. So I think we're going to go ahead and get started. So hi, everyone, and welcome to the October Mary Frances Early College of Education Educator Prep Workshop. Our names are Anna and Emily, and we are student ambassadors for the College of Education. Student ambassador serves as official hosts of the college, and so we are here to support you and your needs. As ambassadors, we plan events and initiatives that cater to the student group along the lines of professional development, recruitment, engagement, DEI, and community service. If you want to get involved, the undergraduate ambassador applications open every January, and information regarding the first Mary Frances Early College of Education graduate student ambassador program will go out this fall. Please reach out to either myself or Emily if you have any questions about the program or if there's anything that you would like to see from the ambassadors this year.
The Mary Frances Early College of Education is proud to welcome today's guest speaker, Dr. Yvette Goetsch. Dr. Goetsch is a current professor in the Department of Counseling and Instructional Sciences at the University of South Alabama and the coordinator for the graduate counseling programs. Her research interests are foundationally rooted in advocacy, empowerment, access, accommodations, and improving services and interventions. Much of her research focuses on childhood chronic illnesses in schools, accommodations, and the impact of chronic illness on families. She is a founding board member of HIVE, Habilitation, Information, Vocation, and Education, which provides a transition opportunity and support for young adults with significant disabilities. Dr. Goetsch was a faculty member at the University of Georgia for 17 years and has agreed to come back today to engage with the Bulldogs once again. Please welcome Yvette Goetsch.
Hello, everyone. I'm going to go through this, and I think the best way, I believe that Anna and Emily will be fielding the chat, correct? And so if there are questions as we go through the material, just go ahead and interrupt me so that we can get those questions answered. And if one of you would be so kind as to let me know when we have about 10 minutes left so that I know if there's information that we need to cover. You pretty much told where I was, so I'm going to skip over some of that simply because, I don't need to go over that. And let me see if I can get my screen to work like I'm supposed to because it's not wanting, there it goes. One of the important things I think is to know who you're talking to. I am a professor and my background is rehabilitation counseling. But also, I have 4 children. I have 5 children, but 4 of my children have disabilities. I adopted 3 children, and they all have pretty significant asthma. And then I have a biological child with asthma, and I have a child with a brain injury who was in a near-fatal car crash. And then I have a child with neurofibromatosis 1. And then I also have a child that has an immunodeficiency. So 2 of my children have growth disorders. And I know that sounds like a lot, but some of them have multiple things going on. And so I was already a professor when I started my family. I decided to adopt while I was at the University of Georgia, and I adopted a sibling group and knew that they all had asthma and knew that the 2 girls both had additional disabilities. So really, one of the things is what is normal. And one of the things that I'll say is that there is no such thing, right? We kind of decide what normal is for us. And for families with chronic illness, normal is living with a chronic illness. Whether or not they had a child that was born with a chronic illness, or if the child developed a chronic illness or disability later on. So I think that's really important for us to kind of think about. The other thing is that I'm really passionate about the world being a better place for everyone, and really about children getting what they need, children and young adults, I should say. Families having access to healthcare and information and resources, and kids with challenges being all that they can be. And sometimes what that requires is for us just to be able to give them, remove barriers and give them the accommodations. That's just a picture of my family so that, kind of I'm a real person. A lot of the pictures are old. My child that is in the middle, well, kind of on the top row, is the one that had the car wreck that was a near fatal car wreck and had a traumatic brain injury along with significant other injuries. but received a lot of support in school, and is now a State Farm agent out in Colorado and is a photographer on the side. So it matters that we think about what's normal for families, because what we think is normal may be very different than what a family has a disability or a chronic illness thinks is normal. And we can take that and kind of be a support for those families. We can make a difference with policies, we can make a difference with legislation, but probably most important, what we can do as educators, counselors, and professionals is that we can make a difference with our attitudes and learning about resources and also offering supports. I'm going to go through a little bit about what we know about mothers and fathers and families who have children with chronic illness, because children are in schools, but school teachers primarily also deal with the families, and whatever happens in the family system also is often brought to school. One of the things that we don't talk a lot about, which is also important, are siblings of children with chronic illness and the impact that a chronic illness has on them when they have a sibling with a chronic illness, because they also need support as well. I'm going to do a couple of quotes from some research that I did several years ago. It really hasn't changed that much as far as what people feel. But for example, a lot of times mothers feel really isolated, and that does impact their children. One of the mothers that I talked to says it sometimes feels like you're in a bubble. The world goes on around about you, and nobody seems to know the conditions or how you're really feeling inside. You have no resources to get you out of the bubble. You're dealing with a sick child and all that, so you don't have any social life. It's a combination of really not having much time, or if you have the time, no money, or if you have the time and the money, you have nobody to watch the kids. That's not an unusual circumstance. A lot of the times chronic illness takes a lot of time for treatment, for doctor visits, for routines within the family, maybe special diets and those kinds of things. It also takes a lot of money, and we're going to talk about the money later on. But also families talking about that other people don't want to watch their children, so they may not have a support group for people to watch their children, or the mothers and fathers themselves may be afraid to let other people watch their children for fear that they wouldn't know what to do if there was a crisis. That also is a fear that they have about allowing their children to go to school. And are the teachers going to be prepared? Are the parapros going to be prepared? Are the school nurses really trained in the chronic illness or disability that the child has? And if there's an emergency, would they really know what to do? And so that's a lot of stress on parents. We talk to mothers a lot more because mothers tend to be more open and more verbal about what goes on. The other thing that tends to be a really big problem is that there's not a lot of respite care for parents and families. One mom said to me, "There's not anybody out there to help me." I don't have anybody like that to say, "Well, I need a few minutes. Can you watch the kids?" I don't have that. People are afraid to watch my daughter. I had a friend of mine, she wouldn't watch my daughter. Because she gets sick so easy, and the fact that she goes from healthy one minute to critically ill the next, people don't want to watch them, and I can't blame them because it's scary. One of the things that we have to realize is that parents get scared too. They're kind of thrown into a world that they didn't know about for the most part. They learn about the chronic illness. They learn how to handle emergencies. They learn how to give medications. They learn how to utilize different equipment or medical equipment. They learn about language, about medications, and about treatments. But it's really not something that they dreamed of doing with their own children, even if they're nurses. So that's something to, for I think teachers and professionals to realize that families are indeed under a whole lot of stress when it comes to just taking care of their children. That's not even thinking about the education of their children. It is just thinking about, oh my gosh, is my child going to be okay? Am I doing the medications right? Do we have enough medications? Do we have enough money to get the medications? Is there a shortage of medications? Which does happen. So all of those things create a huge amount of stress for families. Another mother said, yeah, my son is better. He's home. He looks fine, but he's not fine. I still have insurance issues to deal with. Doctor's office are threatening to report me to the credit folks. And to top it off, my son is not fine. He needs extra help at school. No one gets it. Everybody thinks he's okay. Sometimes kids look okay. I mean, they don't look sick. They don't look like they have a disability. They may be laughing. They may be carrying on with other schoolmates. They may be attending school pretty regularly, and people may not realize that they still need support. They may need extra time on tests. They may need to leave the room for treatments. If they have Crohn's disease, they may need to have extra bathroom breaks. They may get tired during class. They may need to eat snacks to keep their blood sugar up. There's a whole host of things that can go on that people may or may not be aware of. And as teachers and professionals, it's really important for us to educate ourselves. Fathers don't talk as much about the child's disability in general. We don't have a lot of research. We have more than is listed here, but I'm going to be honest. I had a crash on my newer PowerPoint, so I'm using an older one, but there's just not a lot of research on dads of children with chronic illness. We do know that their reactions are different. We do know that a lot of times they feel their role is to support their wife and their children if they're married, or to support their partner, or to support their child even if there's been a divorce. They're usually less informed about the child's illness. They, as a whole, may not go to the doctor visits as often. That's not because they don't care, it's because oftentimes they're at work. The other thing is that they are really often the breadwinner, not always, but often. And so that stress alone, when you hear about the cost, is really important. Fathers sometimes take on a second job. It's not only fathers, sometimes mothers do, but we know that as a trend, it's typically fathers. That means that their time with both their partner or their spouse is limited, and their time with their children is limited. They may not be up to speed on the latest treatments, on the latest information, on the latest medication for their kids, and they may feel a little bit left out. They may get a question and they may feel like they don't know the answer, and that can really hit at the dad's or the father's self-esteem as well. The other thing is that from my research, one father said, I finally realized even my friends don't understand. I called a friend because I had to cancel something due to a flare-up of my child's condition. My friend was obviously perturbed. He said, I thought you were all done with that years ago. The father said, they don't get it. It's always there. We're never done with it. I do think that that's really important for professionals and for teachers to understand that families are dealing with this, and this is not a month-long thing or a 3-month-long thing or a year. They're dealing with a lifetime of a chronic illness or disability, or maybe multiple illnesses. And a lot of times other people don't realize that the child may be better, and so they may not talk about it as much. And then people don't realize the family's still dealing with a whole lot of doctor visits, a whole lot of expense for medications, the fear that their child may get ill again or that their condition may worsen, sleepless nights, ER visits, specialist visits, implications for traveling, for eating out, for kids going and spending the night with their friends, and all those kinds of things. We also know that typically moms have a caregiving role. That's not always true, but it's more typical. One mom says you've got to be organized, you've got to get a schedule. Another one said children are seen by numerous professionals, doctors, therapists, specialists. And so she said, now who's going to take the responsibility for making sure that all these 17 professionals are seen, that whatever they say is followed up on, and that they coordinate and talk to one another. I think people outside think that doctors are able to talk to one another, but oftentimes they may see things in the records, but they're not having, a team meeting like we do in counseling where we're doing a staffing. That doesn't happen very often. And so it really is up to a lot of times the family to carry that information from doctor to doctor. And for whoever in the family is responsible for that, that they make sure that that happens. Another mom said it's like an act of Congress to get that referral to a specialist done. Your child has to be near dead for you to get a referral. We are run a lot of times by insurance companies, and so there's a protocol about how you can get a referral to a specialist. And sometimes that means that children are waiting to get that referral until the primary care physician or the pediatrician has done X, Y, and Z before they're able to get a referral. Teacher-parent interactions, and I know several of you are teachers, and it's really important to understand that parents often come to you and they may be exacerbated, they may be depressed, they may be highly anxious, they may be angry. It may not always be directed at the teacher, but it may come out that way. One parent shared with me this. It was the last week of school. It had been a horrible year. My older son almost died, and we spent months in the hospital. My fifth grader had an assignment that hadn't been turned in for some time and some reason. I approached the teacher to ask her about it. After a few minutes, she looked at me and said, "I know he's had a rough year, but he needs to move on." She refused to take his work, and he made an F for that 9 weeks. This mom was really distraught. She'd gone because she'd found the paper in the child's notebook. It was late. She had asked the teacher about it, and the teacher was really not very supportive and said, well, yeah, he's had a rough year, but he needs to move on. Not taking into consideration that the family was still dealing with a critically ill child that almost died, and this was the fifth grader's sibling. And that had been very, very hard. And she didn't take that back. The child actually got an F for that 9 weeks. The other thing is socioeconomic differences. Children who have disabilities or who have chronic illness, in general, not always, but in general, their families tend to be poorer. We know that about disabilities and chronic illness anyway, that there tends to be more individuals in poverty or in low income. Children from African American and Latino families are disproportionately affected by chronic illness. That's still true even in 2020 and 2023 from the new data. Mexican Americans receive fewer health services than any other group, and that's still true today. The other thing is that there are cultural perceptions of healthcare. There's concepts about health and illness, and they're culturally based. When the pediatrician's diagnosis or management plan conflicts with a family and their culture, it can really decrease compliance, and it can decrease individuals' trust in the system. So communication becomes really, really important between physicians and their families, between families in the school, and sometimes between the physician and the nurse at the school. And all of those individuals need to be communicating well with an understanding that cultural backgrounds make a difference in how they receive information, how the family shares information, how much they trust to share information, and how much they trust both the school and the healthcare system. So always keep, cultural information and a cultural background in mind when you're working with families. The other thing is a lack of insurance. Now, while there are state insurances and things like this, there have been improvements. We can't assume that all people have great health insurance, because that's just not true. Sometimes for immigrants, one of the moms told me, we thought about taking my child to the emergency room. That was the first thing that came to mind, because we didn't have a family doctor and we didn't have insurance. So even for individuals who are immigrants, knowing where to go, knowing if they'll be taken, also fear of people finding out if they're undocumented. What do they do when their child gets ill, particularly if their child has a chronic illness? The other thing is that sometimes they don't know about, what the clinics are, which clinics can you take them to, and things like that. And the other thing is the medical community in and of itself is confusing. You get bills from all over the place. X-ray sends you a bill, the primary doctor sends you the bill, the ER sends you the bill, medications are a different bill, different doctors, bill differently as well. And that can be really confusing for a lot of families. Also, we need to be cognizant, if there are language barriers. The other thing is that sometimes people just don't know what to ask. Unfortunately, in the medical system and in the school system and in our professional communities, there are biases and prejudice and there are assumptions. And so those kinds of things we need to keep in mind. One of the things that really struck me when I was doing research was a mom who was African American, and she had an issue with getting a referral and seeing a specialist. She said, "I'm paying out of pocket." And the person she was on the phone with said, "Well, you can't do that. Do you have insurance?" And she said, "Yes, I do." "Well, you can't pay out of pocket. Your insurance has to pay for it. And they only pay if your doctor has referred you." So I'd call another doctor and tell them I didn't have insurance. "We can't see you without insurance." She'd say, "Well, I'm paying out of pocket. I'm going to pay with cash." "We can't do that. You have to have insurance in order for us to see you." So she was having problems, regardless if she had insurance or said she didn't have insurance, and getting in to see a doctor. So while we would hope that that wouldn't happen, it does. For professionals and for teachers, that's another stressors that family have. Just getting in to see specialists and getting in to see who they need to see is important, as well as if the medication they are on, somehow there needs to be a change. Either the medication's not working anymore, or their insurance, which happens more than people think, decide that they're not going to support that particular medication. It's going to become non-formulary, and the insurance company has decided to use a different medication. And that may put the family in a quandary, because maybe the medication that they're currently on is the one that works really well. And then they have a fight on their hands to actually get the insurance company to pay for the medication that the child's currently on. So real quickly, an overview of some of the stressors include respite. It includes work, whether parents have to work more. Can they go to work? Are they missing work? Money is typically an issue across families, regardless of how much they make. Knowledge and not knowing all about the chronic illness, trying to get a lot of knowledge, misunderstanding, not understanding different medical terms, learning how to give medication, learning the different medications, dosing requirements, giving injections comes along with a lot of that. Maybe learning how to use a feeding tube with their child, recognizing symptoms and when to call the doctor, when to go to the ER, and all those kinds of things, and sometimes time for treatments. For example, I'll just give one, but a child with asthma, if the child is having a pretty significant exacerbation, they may be doing nebulizer treatments at a minimum every 4 hours. It may be more than that. For a child with cystic fibrosis, they have to have specialized treatments that are done every day. That takes time as well. When you take out, just time for certain medications, that is an additional time. Therapies that children may have to have. That may take 30 minutes, it may take an hour, it may take an hour and 15 minutes. Then you have to consider, do they get those treatments at home, or do they have to go somewhere else to get those treatments? So all of that is time. One of the moms says, well, there's work and then there's care for Rose. And the third, well, that's probably it. They are big enough, she's talking about work and care for her daughter, to take up all the rest of the time. And so time becomes an issue as well. Financial concerns, medication is one of those. Insurance doesn't always pay for the medication, or if they do, they may not pay the whole cost. A lot of times there's not a cap on how much you pay for medication. So if the medication, for example, it may be growth hormone injections, that can run as much as $3,000 a month. If your insurance pays 80% of that, calculate that up. That's pretty expensive. If it's non-formulary for some reason, then they may have to pay the entire out-of-pocket cost. The other thing is it generic, or is it a new drug and you can't get a generic for it? So that makes a huge difference. Years ago, that happened with asthma inhalers. And so a copay for a lot of people was $10 for an inhaler. Well, when it went to the fact that they had to change it because of the environment, and they changed how that was administered and how you actually took the inhaler, so the ingredients changed to protect the environment. It went from being a $10 copay anywhere from a $40 to $60 copay, because it went from being generic, now it was not generic. So that was really important. Families and children get drawn into this because they recognize that their parents are stressed, but also they may not be able to do the same thing as some of their friends do. Their family may not be going out to eat. The family may be concerned about paying the bills. Children may hear their parents arguing, or hear their parents talking about maybe, how are we going to make the house payment? How are we going to make the rent payment? What are we going to do? That can leave both children who have an illness, but the siblings, to feeling guilty, to feeling scared, to being afraid that they might lose their home. The other thing is that families learn very quickly that the charges come from all over the place. So I don't know how much you all know about the expense of different things, but it varies and it goes up. But a month of growth hormone treatment can run anywhere from $3,000 to $6,000. One IVIG treatment, which is used for a couple of conditions, but for children with immune-related conditions, that can run anywhere from $3,500 to $7,000 per treatment. That's also true for some of the medications used to treat Crohn's disease, and those are IV. That means that you actually get them through an IV. Those are normally done for example, for immunocompromised children, it may be done once a month. So if you think about that, that's a large expense. And depending on the insurance, or whether or not the child's on Medicaid, and whether or not it's approved or not by the insurance company. And the other thing is that you may have to get reapproval for that, a physician's authorization, every 3 months. Some insurances require that. So you may be in fear that you may not be able to get the medication. Asthma meds for a month, depending on how many meds you're on, can run with copays anywhere from $10 to $100. Without copays, it can run from $100 to $400 a month. A traumatic brain injury with full-time rehabilitation, you're talking about maybe $1 million if it's full-time and you're there for 4 to 6 months. And that's often not fully paid by an insurance company either. And the reason I share this is for professionals and educators to really get a sense of what it's like to be in a family where there is a chronic illness. And so I wanted to do a little bit with just getting educators and professionals to think about a couple of case studies and what might be going on. Andy, we're going to say, has asthma and allergies. He's allergic to milk and milk products, cats, dogs, mold, smoke, hay, and strong smells. He must have a rescue inhaler with him at all times, along with an EpiPen, which I don't think I put on there. The child, he also has Russell-Silver syndrome, which is a growth disorder, and it's rare. He doesn't have a fat layer, so he gets hot and cold easy. He needs plenty of water during recess and PE because he tends to get dehydrated easily. He takes an appetite stimulant so that he will eat as much as he needs to eat because he doesn't get hungry. He has a lipase deficiency. That means his pancreas doesn't make enough of the enzyme that breaks down fat. So in other words, he has trouble with digestion. He also has trouble with bowel movements. So he takes an enzyme pill before every meal to help him digest his food. He has reflux, and he takes a pill every morning and night for that. He has a growth hormone deficiency, so he takes a growth hormone shot to help him grow. He has psoriasis, which flares during cold weather exposure. And he also has ADHD and takes medication for that. So Andy has a lot going on. He has several medical conditions. He also has ADHD. All of these can impact his learning. So school issues, Andy frequently misses school. He's disorganized. He often misses information or fails to write down assignments. Sometimes he fails to turn in homework. He has difficulty completing tasks. And he needs extra snacks during the day because he needs to grow. He needs to make sure that he's getting enough calories. He also needs to make sure that his blood sugar is not dropping because that's also common with children with Russell-Silver syndrome. So getting those snacks also is important for his attention span. It's important for his health. So that's some of the school issues that he has. Keisha is another child. She has a variable immunodeficiency, so she gets sick really easily. She takes IVIG therapy in the hospital every 3 weeks. That means she has to go in overnight and get those treatments. She has mitral valve prolapse, which is a heart condition. She has supraventricular tachycardia, which means her heart gets out of rhythm and breaks really, really fast. She has asthma. She takes Singulair daily, which is a daily medication for allergic type asthma. She has an inhaler as needed. She has migraines and intractable headaches, so she takes medication for those. She has allergies to corn, eggs, and red dye. Okay, think about that. Corn, eggs, and red dye, which is in a host of products. So I'd encourage you to go out and see what you can get without corn, eggs, or red dye. That also means corn syrup. So think about that. The other thing is that she has to get a growth hormone shot nightly as well. So that takes time. And I bring that up because those are things that families and children are dealing with. So children who are frequent repeaters to the hospital, they're going to miss school. Children who are worried about their own health, or they have siblings that are worried about their sibling who's ill. A lot of times siblings say, well, I thought my sister was going to die because all of a sudden grandma came over and mom and dad left and it was an emergency and the ambulance was here and I didn't hear anything. And they just said, well, she's in the hospital. And then she didn't come home for 7 days and they kept telling me she was in the hospital. Well, I thought she was going to die because people die when they go to the hospital. And they're thinking about, things in their head. We need to make sure that there's good communication. Keisha was also identified as gifted, but she has tracking problems. She has dyslexia and she has a reading disability. And so Keisha missed 18 days of school during the year. She's in the gifted program, but she's been tardy to school because of migraines frequently. She often leaves school to go to a specialist appointment, and she's currently below grade level in reading. So a lot of that can be attributed to her disability, but the other things can be attributed to the fact that she's missing a lot of school. She's late a lot, and even when she is there, if you know anything about migraines and intractable headaches, she may not feel her best even after she gets to school. And so it becomes important for us to think about what kinds of accommodations might be there. So some of the issues that are present is that she has a disability in reading. She has a health-related disability. She's going to need access to her inhaler, which laws protect her for that. She may need to be late for school. She may need to have extra time on tests. She may need to have tests given in a different way, maybe orally, because she is below reading level and her headaches may make it difficult for her to do that. If the tests are given via computer and you have migraines or intractable headaches, that can also be an issue. So you may need to think about a different format. Reading for a small print can be an issue as well. Thinking about PowerPoints or different types of visual aids, thinking about what may be better for individuals so that they're not experiencing glare or those kinds of things are important to keep in mind as well. I would say that when you do that, that's a universal kind of accommodation. You can do that, and changing the font, changing the colors, making things less of a glare can be helpful for all students, not just students, you know, who need those specific kinds of accommodations. One of the things that I really talk with parents about, I talk with teachers about, and other professionals and counselors, is really thinking about equality versus equity. So if you look at these pictures, what you can see is that there's a baseball game going on. In the first image, it's assumed that everybody will benefit from the same supports. Well, if you look at that, just because you have a support doesn't mean that everybody is benefiting to the same level. And some people may not be benefiting at all, even though supports are in place. That's why it's really important to work with the parents, the child, and find out what supports are helpful and what supports they actually need. In the second image, people are given different supports to make it possible for them to have equal access to the game. They're being treated equitably, right? So they're given those different supports so that they can all see the game. In the third image, all three can see the game without any supports or accommodations because they actually removed a barrier, and the barrier was the fence that you couldn't see through in this case. So a systemic barrier was removed, and that would be universal design, right? Because now we've taken away something and everybody can benefit from that. So they still have the protection of a fence, but the fence there is one that everybody can still see the game. That's a simple example, but a visual sometimes helps us to understand that everybody getting the same thing doesn't necessarily make it where somebody can learn or that somebody can access the things that they need to access. Even given different support sometimes is not really as helpful as universal design can be, because universal design then will not make the person stand out. The child in the classroom will be getting what they need, and other children that we didn't realize needed that accommodation will also get what they need, and nobody is kind of singled out for that. So that's really an encouraging thing. If you can learn to do things that can really make things more accessible for everyone, that's really important. One of those things that's really simple to do is to look at classroom layout and making sure that children learn to keep pathways clear so that people don't trip, to make sure that people have adequate room in the classroom to do activities. Also, perhaps making it okay for children to stand up or sit down at different times so that they can get some movement for children that may have mobility issues, juvenile arthritis, or other types of pain-related syndromes. The other thing is that making sure that all children are hydrated. So maybe either making it where children can have, water in the classroom, or that there are frequent breaks for them to get that. All of those are things that we can do without making it where the child that has the disability or chronic illness is sticking out like a sore thumb, so to speak, or that other children are really noticing that they're getting something extra. And that can benefit the whole classroom when we do things like that. So FAIR, I really like this. It's an old cartoon. I don't even know how old it is, but for a FAIR selection, everybody has to take the same exam. Please climb the tree. Okay, so we've got a monkey, a penguin, an elephant, a goldfish, a seal, I think, and a dog. Okay, so obviously, if we did that, But we do that all the time in schools. We give people the same exam and we make no modifications, and that's what they're graded on. Or we have a learning environment and we have a PowerPoint and we don't take into accommodations the lighting. We don't take into consideration somebody might have difficulty following along and taking notes, that they can't do that dual process, or they have difficulty hearing. Or they're fatigued, and so they may zone in and out for a little bit. And what can we do to support that? So those are things to consider as well. Sometimes, and this is actually something that I've heard from teachers that have said, and this isn't all teachers, and I have great relationships with teachers, and I encourage parents to build those relationships, because sometimes teachers and professionals just don't understand or have the information. But I've heard teachers say, well, it's not fair that the kid gets a note taker, because they're going to have to learn to take notes because they're going to go to college or high school and they need to take notes. It may not be possible for the child to take notes either physically. It may not be possible for them to do it because they have a limited amount of energy and concentration and they need to listen. They may be an auditory learner, and when they go down to take notes, they may lose what's going on when they're doing that. Or they may experience fatigue, or they may get pain upon writing. So that's important to remember. We already talked about water bottles and extra snacks. Extra time on exams to accommodate for lack of attention, to accommodate for individuals who fatigue easily, or who may have vision issues and fatigue, or they just may take longer for them to write. Children who have mobility disabilities, or they have pain upon writing, may need extra time. Reminders, children with executive functioning issues, children with ADHD, but some other conditions as well, may need extra time to complete tasks, and they may need reminders. And finding out what works is really important, because not everybody, not everything works for everybody. So those reminders may be really important. I put tape recorders there. We have other things besides actual tape recorders, but recordings, note-taking plans. The LiveScribe pen is one of those that actually records, and you're able to actually put your notes on the computer with that. Those are great. And there's other things that can be used as well. One of the other things I wanted to hit on before we stop, because it's 5:17 and I want to be able to take questions, is parents' perspectives. How much time does it take to ask a child for the homework if they have trouble remembering? Or is there another prompt in place? How much effort is it to type in a due date on programs like PowerSchool to make sure that children, when they pull up the assignment, that the due date is actually there? What's the big deal to let a student come a little bit early or stay a little bit late to complete a test? Is that an accommodation that can be made? And I can't read my other one, but there was another one there. What's really not fair is when kids receive low grades because they weren't given the supports that they needed to be successful. And one of those would be extra time, which is a pretty easy accommodation. When kids are given assignments that really conflict with their disability or their chronic illness. One example is, and this actually happened to my child, is consistently he was given a word search, and he has dyslexia and a reading disability. The only thing that did for him was to make him get frustrated, because he literally couldn't find most of the words anyway, and he learned nothing from the assignment, other than he was really frustrated and he failed the assignment every time, and it was a weekly activity. And we really had to battle that, because the teacher was like, well, everybody else has to do it, so he has to do it. We finally were able to get another type of assignment in there, which was one that allowed him to pick from a word bank what was the definition of that word, which was a better learning activity for him. The other thing is, what is fair? When we really work and remove barriers and we provide supports and accommodations, and then when kids are given supports and that skill is faded as the child learns the skill or learns coping skills or learns, their own accommodations. And then when we do things to level the playing field for children, we're not giving them an advantage, because if you have difficulty writing and it takes you 3 minutes to write a sentence when other kids can do it in a minute, giving that child extra time so that they can show what they've learned, that's just, providing a level playing field. So some things that parents have said and other professionals have said that really help is sometimes turning a desk around so that a child can't play with things in a desk if they have ADHD and they get distracted easily. The other thing is making really large, colorful tabs that's easy for a child to find things. The other thing is giving children prompts to get ready before you start the lesson so that they can make sure they get everything ready. The other thing is that making sure that we know that children are listening, and that for some children, not just children with ADHD, some children have processing disorders, some children are tired, that they may have difficulty listening and taking notes at the same time. So those are all things that we can do. The thing that I want to end on, though, because we're out of time, and I hate that, but except for questions, but the difference between accessibility, accommodations, and modifications. Accessibility is being able to use and access or benefit from something either directly right at the moment or somehow indirectly. Accommodations remove barriers to learning and barriers to access. So, for example, having a ramp instead of stairs, or having something that is both read out loud, visual, and experiential, so that all modes are used so that somebody can access it. And then modifications are changed. Are changes made to what expected for the child. So instead of having 4 answers for a multiple choice exam, they may get 3. Or instead of writing 5 essay questions, maybe they only write 2 essay questions that combine information from the 5 questions that were asked. So I'm going to stop screen sharing right now because I really do want to be able to answer some questions. So I'm guessing that our host will actually come in and help me with questions that you may have. Are there questions?
So far, I'm not seeing any in the chat. We can give it a little bit in case there are.
Okay. And it could be a wide range of questions.
All right, I found one question. So it says, what are some ways you can learn more about specific disorders and accommodations?
There's a couple of ways that you can learn more. One is to go onto the website and go to legitimate sources. One would be like if you were interested in learning about diabetes, for example, going to the Juvenile Diabetes Association, you can do that. Also, asthma, you can do the same thing. The Crohn's Foundation of America. And so really looking at that are good ways. Teaching tools, one thing that you can do is to go to Wright's Law. They actually have a lot of accommodations there as well. to learn about, what people have done, what people need to do, and those kinds of things. But most of your major organizations for children with chronic illness, they will have a section on there that's accommodations for children in schools, and they have some really neat resources for you. So the American Diabetes Association would be one of those. And if anybody's interested, I can send a whole list of resources.
And we have another question. What are your thoughts about how support students need when a school nurse is not available?
Yeah, and that's really important. We have a shortage of school nurses. Some schools share school nurses. And when I say share, I was in a rather rural county. That meant that one nurse went to 3 elementary schools, and the elementary schools were 20 to 30 minutes apart. So that meant that she spent the majority of her day doing what? Driving. So how you can support that, one thing is to make sure that you have some type of healthcare and emergency action plan, so that you understand as a teacher, as a counselor, as a support person, whether you're a special educator or a regular education teacher, that you understand what an exacerbation of a chronic illness looks like. What does an asthma attack look like? You want to get the early warning signs of that. What do you do? How can you help the child? What are specific protocols? When should you call? When is it an emergency? And then making sure that you understand a little bit about the condition. You can get that from the school nurse. Oftentimes it's really good as a teacher to say, hey, can we have a meeting with the school nurse and the parent? If there's not a school nurse available, if you can meet with the parent. What is this condition? What are the protocols? And really making sure that those get done. A lot of times children with chronic illness qualify either under the other health impaired, underneath the Individuals with Disabilities Education Act. So they might have an IEP under other health impaired, but most often these children are covered under 504 of the Rehab Act. So they might have a 504 plan. And so if they do, those accommodations and everything need to go in there. A health action plan, an emergency action plan, and any accommodations for the classroom.
Awesome. And then, so another question, it says, in your experience, how do most teachers find out about a child's chronic illness?
Oh, that varies. Sometimes they find out because an incident happens in the classroom. No lie. Something happens and then they realize that the child has a chronic medical condition. And that's a failure on everybody's part, right? I mean, on the parents' part, on, the whole system. Oftentimes they find out because the parent tells them. So that's probably second. Third is they find out because it's in the school records, and the school nurse, if they have one, shares that with them. Sometimes they find out through the kids' friends, okay, because the friends are concerned or a sibling is concerned, and sometimes the child themselves will tell. So there's no real one way that happens. But the most unfortunate way is if there's an incident that happens and nobody really knows, because then you don't know how to take care of it.
And we have another question. Are there any liabilities when intervening with a child when you're the teacher and do not have medical training?
That depends on the state for one thing. But if your state has a good Samaritan law, right, that does offer a lot of people protection. If it's an emergency, but the best protection that you can really get to is if a child has a chronic illness or disability, is that you get particularly those emergency plans in place, and that you understand about the medication. You understand about what the early symptoms might be, like of an allergic reaction. That you talk with your school and you talk with your district about what those the legislation types, the policy issues are, because there are policies that are done, and that hopefully what would happen is that the people that are working with a child would get training. For example, how to use an EpiPen, if a child is having an allergic reaction and the child can't administer it themselves. And that doesn't necessarily have to do with age, right? If a child has a severe allergic reaction, they may have passed out and they may not be able to administer it. So those are different things. So really, the more that we can educate people, the more that we can have those plans in place, and the more that people don't just have a plan that they never read, but that they get training on that. But it really does vary by state. But that's, when you don't have a school nurse, there's usually somebody designated. But honestly, are you going to wait for a child that can't breathe to wait for somebody to help them get an inhaler? Because, that can go south really quickly. So there's not one good answer there, but I do encourage you to talk to your administration and find out, what you need to do and what liabilities there are. But if you're going to have a lot more liability, right? Just in general, if a child does not get treatment and it has a very poor outcome. It's a lot of pressure for teachers. And I hope this was really helpful.
Yes, thank you so much for joining us. We have run out of time now. So thank you so much to Dr. Getch again for joining us. We really enjoyed having you. So next month's workshop will take place on November 14th with our guest speaker, Camille Reynolds, the Assistant Dean for DEI right here in the Mary Frances Early College of Education. Be sure to follow us on Instagram at MFECOE and read the weekly MFE-COE Connection newsletter for updates on all of our future events. And you can also text at MFE-COE to the number 81010 for text updates. So yeah, thank you again for joining and have a great rest of your day.